Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'm going to talk about a very important topic within pediatric emergency medicine. Today I'm going to speak about trauma. And I am not a trauma specialist by any means. I'm a pediatric emergency provider who's had his share with trauma in fellowship and a little bit beyond. And that is why I decided to bring a pediatric trauma specialist, non-surgeon, just like me, to the show. Today I'm going to talk to Nir Samuel, who's going to give us some advice about how to better handle the pediatric trauma patient. Welcome, Nir, to PEM Rules. Thank you very, very much for coming on the show. Like all my guests, I know what you do for a living, and I know how busy you are.
Thank you. Glad to be here.
I appreciate your time. Let me just introduce you briefly to the PEM Rules listeners, and you're going to stop me at any point if I said something incorrect. Nir, you're originally from Jerusalem, Israel, and you completed your pediatric residency, like me, and your PEM fellowship at the Technion Institute of Technology, a place I know very well in Israel. And then after that, you completed an additional pediatric trauma fellowship at the Alfred Major Trauma Service and National Trauma Research Institute in Australia. How long was that fellowship, Nir?
So that was about a year and a half. Actually, the Alfred Trauma Service is an adult service. It's the largest in Australia and the fifth largest worldwide. And I also did that in collaboration with the World Children's, which is the pediatric largest trauma center in Australia. So it's a dual adult pediatric trauma fellowship, major trauma fellowship. Yeah, that's right.
Currently, you're a PEM physician and a trauma specialist at the Schneider Children's Medical Center in Israel. You also serve as faculty at the Tel Aviv University School of Medicine. I don't know how in the world you found the time. You also did a PhD, and you do a lot of research on focusing on trauma research and predictors of life-threatening conditions and anticipated emergency interventions. Did I miss anything?
No, I think that's about that. Yeah.
That's about it. No, that's quite a lot.
Glad to be here. Glad to talk trauma.
I'm happy that you're here. And the first question to you is the question I ask all my guests on PEM Rules. Everybody has their own answer and their own perspective. What is your definition of a good PEM provider? One who does what?
A good PEM provider is versatile. It's in the end of the day, it's getting the kid across the road, right? So we have to know to fall on our feet. We have to know to think wide. We don't necessarily have to be the best at everything, but we have to be proficient at everything. And that's what I think makes a good trauma to our skill set. Something I'm very passionate about. We're talking a lot about this down the talk. But basically, being versatile, thinking wide, doing all that's needed.
All right. I agree with you, Nir. There's a lot to know and a lot to do, and we better be proficient in what we do. It's easier said than done sometimes. My next question to you, Nir, and again, this is something I think all of us are very familiar with. You practice outside of Israel, and you probably know in the US, majority of children get seen in general emergency department by providers that are mostly trained in taking care of adults. In many children's hospitals, like the one I work with in Vegas, there's a trauma team that is composed almost solely of adult providers, adult surgeons or general surgeons, general emergency physicians. They take care of the children. They call me intermittently as they need, if they're very busy or if there's a multi-trauma or if it's a very young child. But for the most part, they take care of business themselves. And my questions to you is, what advice would you have for those trauma personnel who, for the most part, again, only take care of children a minority of the time? What are some things that you want them to know for the treatment of pediatric or newborns or toddlers trauma patients?
So first, I'd have them know that what they're doing, although it may be intimidating, that's actually the rule. So most places around the world, in the States, in Australia, in Canada, Europe, whatever, also in Israel. So once there's potentially severe trauma and the trauma team gets activated, that trauma team would most likely be adult trauma providers. And there in the Western world, their pediatric caseload would be roughly 10%. And so we're obviously less confident and perhaps less proficient at what we do what we do less. But having said that, we have tools tools to address this. And so I take that question just a step back and ask ourselves, what is truly pediatric trauma? Is a 16-year-old a pediatric trauma? Is a 14-year-old a pediatric trauma? And when we're talking pediatric trauma academically, we're usually talking about 14 years of age and below. But taking this further, there's just been a recent article that showed that for the adolescent, for the older child, the outcomes for adult providers are equivalent to those of pediatric providers, which is, I find this embarrassing as a pediatric provider, but that's a good kid. That's a good thing for kids, obviously. So the first thing is that's okay. Okay, that's currently the norm outside of the largest pediatric hospitals in the world. And the second thing, I think we've done kind of a disservice to kids, advocating that kids are not young adults, and that's or small adults. That's obviously true, but we've taken that message, I think, to an extreme. Okay, to causing a situation where adult providers are too apprehensive to treat. So on the one hand, we do have data to support that kids do better in terms of outcome, especially younger kids when treated by pediatric teams. But when you're in a department, a mixed department, a regional, or even a level 1 trauma center, and you're the trauma provider, you're the person most skilled. So I think you'd want to lean on your strength, and lean on your strength is knowing that a kid, like an adult, needs to oxygenate. A kid needs to perfuse. So the basic game plan stands for kids. And you should know that for kids with an equivalent severity to adults, kids actually do better. They survive better. So it's about getting them oxygenated and getting them perfused. And that's for the initial part of the trauma resus. The trauma resus, like any resus, is about maintaining physiology and aiming for definitive care. And so what are the challenges? The challenges are often the pediatric airway. The challenges are the difficult IV access in a child that may be in shock. It's a challenge for adult trauma resus, so all the more the same. And it's a challenge when you ask yourself, okay, should I just copy paste what I'm doing to kids, or should I be doing something differently? So, I've read this article about Messi. Messi, I don't know if you're in the States, you're not a big soccer fan, but he's one of the current legends of soccer. He still is a legend, but he's playing much differently today than he did when he was young. When he was young, he was faster and stronger, and today he's basically smarter. To make a long story short, he plays the game better. So it's about not trying to be a pediatric provider. You're not gonna manage that. It's about being a smart adult provider treating kids. Now, how do we do this? So, as you've mentioned, we work in different setups. We can be in a level 1 trauma center. We can be in a regional. We can be far off from a pediatric trauma center. It can be relatively nearby. And I think, like when treating adults, you want to know specifically for your department, specifically for your institution, what is your game plan? What are your supports when treating kids? So in terms of trauma team leadership, it's pretty much the same. And when we're talking about procedural competencies, so you should know, do you have a good, who's the most senior airway provider you can lean upon in your institution in a given shift? Where is your pediatric trolley? Okay, you want to know this trolley. You want to know when everything is. You don't want to get oriented and acquainted with it for the first time when it's sick. When a sick trauma comes in. You want to know this beforehand. Open all the drawers, look and see where everything is. When we're talking pediatric airway, usually when I talk with my anesthesia colleagues and I said, well, listen, I had a difficult intubation on a kid, and they usually snarl back and say there's no such thing as a difficult intubation on a kid. And they're right and they're wrong. They're right because usually kids are much anatomically simpler than adults, right? Unless they're down or pre-orbital or those. But the ordinary kid is an easy anatomic intubation. The difficulty usually comes from situational difficulty. Our own apprehension, the fact that kids have lower respiratory reserves and they desat faster. And so the way to handle that is knowing who's your most qualified providers to handle the airway, and also having fallback. SGAs are excellent for kids. Front of neck access, not so much, but we usually get away with supraglottic devices. And chest drainage, again, when we need to handle, when we need to decompress a pediatric chest, okay, first ask yourself, is this needed? If a kid is in shock but is satting well, he's unlikely to have a massive tension pneumothorax. He may need drainage down the road, but he doesn't need an emergent drainage, which means you have time to get the most adequate provider. And if you do need to drain a pediatric chest, just know this. The point, as in adults, is about pleural decompression. Putting in the chest tube, finding the exact size, you should have the Breslow ruler, and you should have, you have the resource to find that out. But that's not a time pressure thing. And we're talking about circulation. So access may be difficult. That's not new for anyone, but it may be more so in kids. And so if we can't get peripheral IV access, and if the kid is too young or too small bore for a recline, a rapid infusion catheter, I assume at least part of you are aware of this device. So we want to go intraosseous. Personally, I've experienced all systems. I have no conflict of interest, just to say this. The bone injection gun and the EZ-IO system. The EZ-IO system is in my experience, but more importantly, as the evidence goes, a far superior system, and that's the one I'm using for kids and adults today. And that's the way to get initial vascular access when peripheral access fails. Admittedly, not the same flows we're used to in PIVs, especially not when we're giving blood. But that's usually an adequate bridge to a better access.
And I agree with that. My experience with the IO is fantastic. I always tell the residents, IO can save a life. Easy, very quick. My nurses are excellent with the IVs, but when it's taking too long, I think the IO is a great option. I agree with you.
Yeah, I agree. And like a lot of things we do in emergency medicine, I think the barrier you have to pass is the cognitive decision, right?
Right.
Implementing and deploying it is super simple. Oftentimes, what delays it is not the deployment, but the decision to go beyond the PIV to the EZ-IO. So I will say this: just a big study published just last week in, I think, Resuscitation, looked at adult and pediatric complication rates while using IOs. I think it was intraosseous access, sorry. And it was negligible in adults, and it was virtually non-existent in kids. And that was a national study, I think, done in Denmark, if I remember correctly. So IO. And the second question regarding circulation, once I have access, what do I give? Do I give crystalloids? Do I give component therapy? Do I give whole blood? So in this respect, kids are small adults. So we have data to support. We have increasing strong data to support that, like in adults, we'd rather not give crystalloids. We may give component therapy. And we do have an added benefit, as in adults, for whole blood, low titer O whole blood. So if you're holding that in your departments, on the floor or in the blood bank, give the kids as well, okay?
I agree with you. We do that in our trauma center. I mean, it's putting it simply, give the patient what they're missing. So why giving fluids when you can give blood?
Yeah, so salt water is for pasta and blood is for bleeding, right? That's Spinella.
Beautifully said.
Yes. Okay, moving forward. So disability. So disability in terms of assessment and injuries. So oftentimes assessing a kid neurologically for a non-pediatric provider would be a challenge, especially that some kids are, of course, too young to be verbal, and they're often in pain or in anxiety. So mitigating that, mitigating their pain with analgesia having a parent in the room. So that's something that's counterintuitive for some, but we know from medical research and also trauma research, and there's strong evidence supporting this. Having a parent in the room is good for the kid. It's good for the parent. It's even good for the parents if things don't go well. So we strongly advocate for having parental presence during recess. The only caveat to this is if the parents can't handle this, or the provider feels they're impeding care and causing an extra burden for him, that's okay to ask them kindly to step aside, usually with trying to have a social worker with them. But I often, if the situation allows this, I examine a kid in their parents' lap if possible. Okay, to that point, it gets the situation much better. Analgesia. Okay, analgesia is good for the kid, obviously. Once things calm down, and perhaps with a bit of ketamine, a bit of minimal sedation, our heart rate goes down as providers, and we're more thoughtful and more deliberate, and procedures go better. So in the hemodynamically stable but very anxious child, you should, I think, strongly consider some sort of minimal sedation to help the child and help ourselves evaluate and treat them.
I'm going to ask you a question exactly about that, Neil. I'm going to pause you for a second because I was in that situation, and I do love ketamine. It's a great drug. In the setting of trauma, if we're concerned about any bleeding, whether internal or external, we do know ketamine raises the blood pressure 100% of the time. Is that a concern?
Actually, I was thinking the other way, so that you'd ask me if a kid is catecholamine depleted, wouldn't ketamine push him over the edge? So I'll discuss blood pressure. I'll discuss blood pressure targets in a second, in another aspect of this. But bottom line, it's safe. I'm not worried of overshooting blood pressure targets by use of ketamine. We've actually published about procedural sedation in the trauma bay for severely in the trauma bay. Sorry, and what we show that in a kid that comes in GCS 15 and in a kid that is hemodynamically unstable, having him sedated for a CD exam, as an example, did not result in adverse events, did not result in any adverse outcomes. We did in a cohort of about 500 kids have 2 kids that had potentially unanticipated intubations that went well. We couldn't attribute this directly to the sedation, but that's the only asterisk I'd put over it. But bottom line, in a hemodynamically stable child that needs procedures, that is anxious, we can use mild sedation. Ketamine is actually a good option. Second thing I'd like to talk about in terms of stability, and we come back to your important point here on about blood pressure, is TBI. Okay.
Yeah.
So as in kids, as in adults, sorry, TBI is the number 1 cause of death. Hemorrhagic shock is the number 1 preventable cause of death. But actually, in terms of when you look at emergency surgery, the chances of a severely injured kid having a severe TBI is relatively higher than in adults. So we should always keep in mind, even if we see another injury, torso trauma, for example, keep in mind TBI, and so we want the head imaged. And what we do not want, so we're all familiar, I guess, with the concept of hypotensive resuscitation, or in adults having systolic targets around 90 millimeters mercury in adults. This has come into controversy again in adults, especially in the elderly. But in kids, we do not. We want a normotensive patient. That's the bottom line. And the reason is that we assume a high likelihood of traumatic brain injury, and we want to safeguard the cerebral perfusion pressure. So I'm actually not worried about too high blood pressure. I'm unlikely to overshoot blood pressure targets. I'm more worried about hypotension. That would be my take on this. So another thing is the GCS, the Glasgow Coma Score. Going back to assessment for a second. So the GCS, as I'm sure you know, has been developed and validated for prognostication purposes, for research purposes, for decision making in the trauma bay. The AVPU scale gives you what you need to know. In my experience, especially in kids, telling a provider get an age adequate GCS score is, I can tell you this in a podcast right now. Implementing this on a hectic floor would be more difficult. So what I advocate for is an AVPU assessment, at least initial assessment. And in terms of going back to airway management, Glasgow 8 intubate, that dictum in adults has been put under strain, rightly so in my mind. And for kids, and we've talked a bit about challenges with airway management, if the kid is oxygenating and ventilating well, and this is something we can gauge readily with anti-capnography, side stream, nasal, and of course with pulse ox, there's no rush to intubate. Okay, we have data that even if intubation is eventually needed, it has better outcomes done in theater. And there's no time pressure to intubate a patient if he's oxygenating well, and if he's ventilating well. That's true in adults, and that's even more so in kids. And the reason I'm discussing this airway issue in the disability part of our chat is that we know that suboptimal airway management in adults and kids may harm prognosis. So we want any procedure, especially airway management, done when needed and in the best possible setup we can get that kid in that time of day in a specific institution. So I'll just go down the road to exposure a few pediatric specific pointers. So kids may be not verbal, and that makes the chances of us missing a potential injury higher. Another thing we should keep in mind always when treating an injured kid is the potential for a non-reported, non-accidental trauma, whether it was inflicted by the caregiver bringing him in, or maybe it was done in kindergarten or by someone not the parent or caretaker bringing in. So always look for missed injuries. That's also a good rule for trauma, especially so in kids. So we have a higher chance of missed injuries. Another thing is temperature control. So kids, their mass to surface ratio is different than in adults, and they're more likely to be hypothermic. And unfortunately, they suffer the same terrible triad or today deadly diamond of trauma. So hypothermia does not do them a service. We've discussed family presence. And so that's the basic pointers about initial assessment of kids. So going back to your original question, Yaron, kids are not small adults, but they're not aliens. We want them to oxygenate and perfuse. We have similar game plan in terms of trauma team leadership, in terms of which procedures are needed when. We want to know our setup. We want to know our shop in terms of equipment, in terms of personnel to support us. And if we're not good with kids, we want to know how to cheat in a way that gets the kid across the road. So if we're not good with intubation in kids, then we want to know who we have in our institution. That is, we want to have SGAs. We want to have ready aids on our cell phone or on the wall of resus bay for landmarks, for chest drainage when needed. We want to know what our fallbacks are for access, mainly IO. And these are, my first thoughts about this. And also, we want to know when we can stand down. So we've done recently a national study. We looked about over 80,000 kids coming into trauma team activations, and we saw something very interesting. We saw that the chance of them, the baseline chance of them needing emergency surgery, which is surgery for the head or torso, or spine, pelvis within 1 hour. Well, we're at 2 to 1,000. These are Israeli figures, but they replicated figures in the States. But what's more interesting is that we saw that if the kid came in alert, and if his heart rate and blood pressure were not in the high risk zones, and if he was the victim of blunt trauma rather than penetrating trauma, his chances of needing emergency surgery dropped to about 2 in 10,000. And we pretty much replicated that scale going to ISS 15 and above, so to severely injured patients. So what does this tell us? It tells us that if there's a trauma team activation, the kid comes in alert and his vitals are fair, we have time to pause, breathe, and think and adapt our game plan. And so these are my thoughts when talking trauma. And I think in my experience, I either talk pediatric trauma to adult trauma providers, or talk pediatric trauma to acute care pediatric specialists. So having these kids treated well often requires a pivot. But my point is, it's less of a pivot than most people think. So taking your adult skills and adapting them to children is something that's completely doable. I, of course, recommend, if something is out of our comfort zone, we want to train at it. So having high fidelity simulations in collaboration with pediatric colleagues is always a good way to train, to reduce apprehension, to test not only ourselves, but to test the room in terms of equipment, in terms of setup, what works well, what doesn't work as well. My final thought about this is, other than thanking you for having me, is just to talk about how important pediatric trauma is. So when we're talking about death from 0 to 18 in the United States, and these are figures that have been known for a few years and recently republished in the New England. So the number one cause of death, 0 to 18, is trauma. And that's in the States, these are CDC figures.
Yep.
And malignancy is far, far second. And then all the rest of pediatrics. And this stays true until the age of about 45. So trauma is number one cause of death from 0 to 45. And that obviously covers 0 to 14 or 0 to 18. So it's well worth our effort as providers to talk about this, to practice for this, and to prepare for this.
Very, very well said, Neil. Thank you for all those tips. And I got to say, as a pediatric provider, not as specialist as you, I couldn't agree more with the IO and giving blood and the supraglottic airways. I think we often get very hung up on getting the tube in. All those things you said, I'm really happy you said that. And I like what you said in the end. The more we practice, the more we save a life. I agree with you 100%. Thank you, Neil, very, very much for coming on the show. I really, really appreciate the comments and the information. And you kind of know the drill. The guests get to choose the outro. You made it easy. I guess you were a teenager in the 90s like I was, and you wanted to hear a song by Eddie Vedder. Sirens by Eddie Vedder?
Yes, I think it's a very Eddie-oriented song. That I think.
I should be able to make that happen.
Thank you so much for having me, Alan.
Thank you very, very much. And that is it for today, guys. Thank you very much for listening to PEM Rules and listening to Nir and his great advice. I think what he said in the end is very impactful. Trauma is the leading cause of death in children, and we as pediatric emergency providers are in the front line. We get an opportunity to save a life by following relatively simple, easy steps. So thank you, Nir, for all those advice. Thank you for everybody who's listening. Please check out the website, check out the Facebook page, and get in touch with any pediatric emergency medicine topic of your choice, something you want to hear about. If you want to come on the show as a guest, I'm always happy to have you. This is, as promised, Sirens by Pearl Jam. Great song indeed. Thank you, Nir, for that choice.